Hello, one and all. Today we'll be discussing one of the important topics in neonatology, that is enteral nutrition in preterm. I will be covering this presentation under the following headings. We all know that when fetus is inside the mother's womb, he receives continuous supply of nutrition through umbilical cord, and thus there's a continuous IV infusion of nutrients. However, when the baby is born and the cord is cut, there is interruption of this continuous nutrient supply, and we need to establish a gut line in order to promote nutrition. Why is it important to start early aggressive nutrition? It's because majority of the transfer of nutrients, including minerals, occur during the last trimester. Therefore, when a baby is born preterm, he is devoid of these nutrients. Also, these babies are prone to various morbidities, which put them at risk of high energy expenditure. Therefore, these babies with inadequate stores and high energy expenditure, if they are not given proper nutrition, they have a tendency to go into negative nitrogen balance. One should also remember that fetal growth is a period of rapid growth. Between 28 to 40 weeks, there's almost double link in the weight of the fetus. Also, there is a increase in the length by 20 centimeter, and brain growth increases by almost 3.5 times. A fetus usually grows at the rate of 16 to 18 grams per kg per day, and to replicate this growth postnatally is difficult unless and until we are very stringent on nutrition. The expected growth of a postnatal period is between 10 to 15 grams per kg per day of weight gain. The length should increase by 0.75 to 1 centimeter per week, and there should be a gain in head size by 0.7 centimeter per week. However, one should also remember that weight loss of 1 to 3% per day is normal in preterm neonates, and there can be a cumulative weight loss of up to 10% within the first 7 to 10 days of life. However, these babies regain birth weight by 10 to 14 days of life. In HGA babies who have very less of extra cellular fluid, those babies tend to lose very less weight and tend to regain birth weight faster compared to AGA babies. Nutrition is important not only for physical growth but also to achieve an optimal brain growth. Therefore, optimal nutrition is important for achieving an appropriate neurodevelopmental outcome and also to prevent diseases like coronary artery disease and metabolic syndrome. It is important to know that not only inadequate nutrition but excess nutrition can also be harmful. If we give inadequate nutrition, the brain is going to suffer. On the other hand, if we give excessive nutrition, especially in small for gestational babies, they become prone to coronary artery disease and other morbidities such as metabolic syndrome, hyperlipidemia later in life. Therefore, there is a fine balance between brain and heart. And if one has to choose between the two, it's always important to choose brain, because for other non-communicable diseases like coronary artery disease, hyperlipidemia, we have treatment available. But once there is impairment in the neuronal tissue and there is neurodevelopmental impairment, it is difficult to correct. The goals of preterm nutrition should be to maintain lean body mass and body mass appropriate for age and gender, also to prevent complications such as bronchopulmonary dysplasia, NEC, and sepsis. As we already discussed, nutrition is also important to achieve an optimal neurodevelopmental outcome, and it's also important to prevent diseases like metabolic syndrome later in life. Before going further, we should know what are the physiological limitations. In premature babies, there is neural immaturity in the form of lack of coordination between suck, swallow, and respiration. Therefore, different modes of feeding are utilized based on the gestation. Also, the stomach cavity is quite small. There is delayed in gastric emptying, therefore, they can have more reflux of stomach contents into the esophagus. Also, there is quantitative and qualitative deficiency of enzymes which are required for digestion of various nutrients. The other systems, such as kidney, has low glomerular filtration rate and poor urinary concentration, therefore predisposing these babies to hyperaponinemia if high protein diet is given to these babies. Also, high fluid rate has been associated with increased incidence of patent ductus arteriosus and bronchopulmonary dysplasia. As a pediatrician or as a neonatologist, we need to know what milk to start, when to start, how much to start, how to advance, what should be the method of the feeding, and when should we fortify our feeds. We all know that breast milk is nectar of life. It is not only beneficial for neonate, but also for mother and society at large. For mother, it prevents breast and ovarian cancer. It promotes an evolution of uterus. It is a ready-made available to the mother. She doesn't have to cook, clean the utensils, and it comes free of cost. Also, it promotes bonding between baby and mother, less chances of depression and anxiety. For society, it's cheap. There is decreased rates of infection, decreased mortality. Therefore, comes at a considerable cost benefit for the society, and there is less burden on healthcare. For the preterms, breast milk is known to decrease necrotizing enterocolitis, sepsis. It has a dose-dependent relation with BPD, decreases ROP, also decreases chance of readmission, and it helps in improving neurodevelopment outcomes for these babies. A word or two about pasteurization. There are two methods, Holder and flash pasteurization. The flash pasteurization, that is high temperature for a shorter period of time, is better than the Holder methods in preserving the cellular components, that is cytokines, growth factors, immunoglobulins, compared to the Holder method. Now, are there any drugs for increasing milk production? The only drug which has been shown to increase the milk output is domperidone. In the recent meta-analysis published in 2018, it has to be taken in a dose of 10 mg per day, thrice daily, for 5 to 7 days. One has to remember not to combine it with another cytochrome P450 inhibitors like antifungals. One should restrain from prescribing herbal drugs because the side effects are unknown and they are hardly reported in the literature. Now, what is minimal enteral nutrition? It has to be started in all preterm babies, especially those who are less than 32 weeks. Preferably, mother's own milk should be given. If it is not available, then donor EBM can be given. It has to be given at the rate of 10 to 15 ml per kg per day and can be divided into 4 to 8 feeds. It can be started as early as possible once the baby is hemodynamically stable. Severe high hemodynamic instability, necrotizing enterocolitis, intestinal obstruction are contraindications. However, one should remember that ventilation and umbilical catheter are not contraindication to MEN. According to the latest Cochrane, it has been shown that it decreases the duration of TPN, time to reach full feeds is decreased by 2.5 days, it decreases hospital stay by almost 11.5 days without increasing incidence of NEC. This is because of the trophic effects of milk, which increases the circulation, improves the enzymes and hormones responsible for digestion and assimilation. Before deciding on when to start feeding, following things should be taken into consideration: the gestation maturity, level of sickness, whether there is any Doppler compromise in the form of AEDF or RADF, other morbidities like asphyxia, whether EBM or donor EBM is available or not, and whether the baby has past stools or there is any abdominal distension. The first milk produced by the mother is colostrum, which is high in protein and includes cytokines and antimicrobial peptides. It also includes lactoferrin and lactalbumin lysosomes. It is the richest source of secretory immunoglobulins A and has got various growth factors. The Oropharyngeal colostrum prevents microbial addition by the presence of oligosaccharides. It stimulates the gut-associated lymphoid tissue. It contains lactoferrin, which has got prebiotic and anti-inflammatory actions. It also has antibacterial, antiviral properties. It chelates iron, thereby preventing supply of iron to bacteria and viruses. The colostrum also stimulates intestinal growth and repair by the help of EGF. In the meta-analysis which was published in 2018, the only benefit shown by oropharyngeal colostrum was decrease in the duration of hospital stay. However, a recent meta-analysis, which consists of around 8 RCTs involving around nearly 700 babies, showed a almost 60% decrease in ventilator-associated pneumonia. Also, time to full enteral feeds was decreased by almost 2.5 days. There was trend towards decreased mortality and NEC. However, it did not decrease the rate of sepsis. This was published in the pediatric research this month only. Now, there are various feeding methods which are available, such as cup, bottle feeding, and if the baby is not able to take orally, we can either choose orogastric or nasogastric tube. The method also depends on whether to give bolus or continuous, and we have a method which we use in our practice that is called syringe method, where the milk is given with the help of syringe and a nozzle is attached to it, and the baby sucks from the nozzle. Between cup and bottle feeding, cup feeding is usually preferred, especially in setting like ours. It has been shown that cup feeding improves the transition, that is, the babies have high rates of full feeds coming to the breastfeeds at the time of discharge. It improves physiological stability by decreasing the episodes of bradycardia and desaturation without increasing the risk of aspiration. Bottle feeding is usually discouraged because it is difficult to clean and maintain hygiene, and it also leads to breast nipple confusion, which can hinder direct breastfeeding. Between orogastric and nasogastric feeding, the latest Cochrane, which was published in 2013, was inconclusive. However, there has been the latest RCT, which has been published in this month only, which consists of 98 stable preterm babies, more than 28 weeks of gestation. They excluded babies with IUGR and those who had umbilical artery catheter in place. The primary outcome was time to full feeds. These were relatively larger babies. What they found was that time to full feeds, time to regain birth weight, risk of aspiration, TP and duration were significantly lesser in the nasogastric tube. So our common notion that babies are obligate nasal breathers and should do better on OG feedings has been challenged by this study, and it may not be an exaggeration if we change back to nasogastric feeding in future. The authors explained lesser risk of aspiration in nasogastric tube by postulating that when we place an orogastric tube, it leads to excessive salivation. The excessive salivation can in turn lead to increased aspiration and increased displacement of the tube. Also, orogastric tube, if placed for larger period of time, can lead to palatal furrow. Therefore, one needs to see that whether orogastric feeding is really beneficial or not in larger randomized controlled trials. Now, advancement of feeds, whether we should advance slowly or at faster rates. The recent Cochrane, which was published, consists of around 10 RCTs with nearly around 4,000 babies less than 32 weeker. All babies are PLBW. The time to achieve full feeds was faster in babies whose increment was done at a rate of 30 to 40 ml per kg by 1 to 5 days. The babies regained birth weight earlier, and there was no increased rate of NEC, and there was no increased rate of mortality. There was a slight increase in the risk of invasive infection by around 15% with the borderline confidence interval. However, the latest trial, also known as the SIFT trial, that is speed of increasing milk feed trial, which consists nearly of around 3,000 babies, compared 30 ml increment with 18 ml per kg per day increment. The primary outcome they studied was survival without disability at 2 years of life. There was no difference in both the groups. Also, late onset sepsis was slightly lesser in babies with faster increment. The rates of NEC were comparable in both the groups. The time to fill feeds was less by 3 days, although it was not statistically significant. So, faster increments is safe and feasible and can be practiced. However, one should take caution in babies who are less than 28 weeks and less than 1 kg. Now, whether to give bolus or continuous feeding. In the last Cochrane, which was published way back in 2011, there was no difference, and there was only a small number of babies. In subgroup analysis for babies less than 32 weeks, the continuous feed was associated with less time to reach full enteral feeds. But the disadvantage with continuous feeds is that the fat can stick to the tubings and can lead to nutrient loss. Also, continuous feeding requires syringe pump and monitoring, which may not be feasible for every country, for every NICU. Other commonly practiced thing is non-nutritive sucking, that is sucking at an empty breast or sucking at a nipple. The latest Cochrane, which consists of around 12 trials, nearly around 800 babies, showed that non-nutritive sucking decreases transition to oral feeds by around 5.5 days, and it also decreases duration of hospital stay by around 4.5 days. These are the beneficial effects. Apart from that, non-nutritive sucking decreases pain, so it's also improves neurodevelopment outcome. Feed intolerance. Before labeling a baby as feed intolerance, one should know the definition. To say baby is having feed intolerance, there should be interruption of feeding by 24 hours or more. However, before labeling feed intolerance, one should know that 50% of the preterms babies have feed intolerance, but however, only 1/4 of these develop NEC. Gastric residual is common in preterm because of the paradoxical motility that instead of going down, the contents of the stomach can move up into the pharynx. Therefore, one should be very concentrate before labeling as a baby with feed intolerance or stopping the feeds or labeling it as a suspect MFC. Always be cautious before making the decision. Don't be in a hurry to stop feeds. Now, assessment of feed intolerance, one has to assess both the quantity as well as the quality of the aspirates. Quantity wise, more than 50% of the pre-feed aspirates, if they are present, it is significant and you can skip one feed and reassess the baby. If there are no systemic signs, no aspirates, one can restart the feeds. Quality wise, if the aspirates are blood tinged, they contain bile or have fecal matter, it is abnormal and one should completely stop the feeds till there is complete resolution. If there are associated systemic signs in the form of shock, one should hold feeds for 5 to 7 days based on the persistence of signs and symptoms. Any baby who's on respiratory support should have an orogastric tube in place, which should be kept open to prevent aerophagy. And remember that electrolyte imbalance is quite common in these babies. Therefore, one should always rule out dyselectronemia, especially hypokalemia in these babies. Now, another important question is that how should we feed babies who have abnormal Doppler in the form of AEDF and REDF? The largest trial, which was known as ADAPT trial, that is abnormal Doppler enteral prescription trial, which consists of around 400 babies less than 35 weeks. They had IUGR babies with abnormal Doppler, and they had two arms. One arm, feeding was started on day 2, and on the other arm, feeding was started on day 6. The full feeding was achieved earlier in babies who had started feeding on day 2 by 3 days. The rates of NEC were not different between the two groups. Early feeding also decreased duration of TPN. However, when they did a subgroup analysis of babies less than 29 weeks, the time to full feeds was higher in babies who were less than 29 weeks. It was 28 days compared to 19 days for babies who were more than 29 weeks. Also, the rate of NEC was much higher in babies less than 29 weeks. It was 39% compared to 10% in babies who are more than 29 weeks. So for babies who are less than 29 weeks and have abnormal Doppler, one should be very cautious in starting and escalating the feeds. Now, how much should we feed? Normally in Western NICUs, the maximum volume which is given to the babies is around 140 to 160 ml per kg. But in country like ours, we even go up to 300 ml per kg per day. In the latest trial, which was published this month only in Journal of Perinatology, it consists of around 224 babies of less than 32 weeks. The primary outcome was growth velocity at 36 weeks. The growth velocity was statistically significant and better in babies who were fed higher volumes. Also, the postnatal growth failure was much lesser, that is 12% compared to 21% in the low volume group. So all the growth parameters, weight, head circumference length, and mid-arm circumference were better in high volume group. And more importantly, there are complications which are associated with high volume, that is bronchopulmonary dysplasia, hemodynamic PDA, NEC, were similar between the groups. Therefore, it is safe to give higher volumes, even up to 200 ml per kg for preterm babies without any risk of morbidities. So the calorie density was comparable in both the groups. Because of the higher volumes, the babies in higher volume group tend to receive more calories, although the calorie density was same. Therefore, the weight gain and other parameters can be explained by this fact. So in a nutshell, babies who were fed higher volumes were having better weight at 36 weeks by 165 grams, had larger head by 0.5 centimeter, had better length gained by 0.5 centimeter, and were less likely to have postnatal growth failure. A word about transfusion associated NEC. Different NICUs have different practices. Some withhold feeding, some continue with the feeding. The meta-analysis, which was published in 2017 from 7 non-RCTs, showed that withholding feeds decreases risk of NEC by almost 50%. A recent trial known as the FEEDUR RCT, that is feeding during red cell transfusion, had 3 groups. In one group, this withhold the feeds. In another group, the maximum limit was only up to 120 ml per kg, did not give feeds more than that. And in the third group, they continued feeds as usual. Each transfusion was taken as a separate event. Therefore, 41 preterms were studied between 23 to 32 weeks of gestation, and 60 transfusion episodes with 20 episodes in each group were studied. The primary outcome was a physiological parameter. With the help of NIRS, they measured mean splanchnic cerebral oxygen ratio, mean splanchnic fractional oxygen extraction before transfusion, during transfusion, and after 12 and 24 hours of transfusion. The NIRS gives the measure of regional saturation. So what they found was that there was no difference in splanchnic oxygenation. The clinical outcomes in the form of time to return to full feeds, abdominal distension, adverse events like NEC were similar in both the groups. There was no episode of proven NEC or mortality in any infant. That is, the background incidence of NEC was very low in this study. Also, whether this physiological study can be translated into clinical practice is very difficult to comment upon, because there are no guidelines or there are no cutoffs for splanchnic oxygenation or splanchnic regional saturation. Also, the feed intolerance was higher in babies who were given full feeds. So it may be safe to withhold feeds during blood transfusion till we have an RCT to answer this question. Now, when should we fortify? Should we fortify early or should we fortify late? The early fortification, according to the latest Cochrane, which was again published this year only, they defined early fortification as less than 100 ml per kg per day or started within first 7 days. They consist of 2 trials. In one trial, the fortification was done at 20 ml per kg. In another trial, it was done at 40 ml per kg. This Cochrane consists of around 237 babies, and there was no or minimal difference between the two groups. So whether you start early or late fortification hardly makes any difference. Also, NEC was not increased if we start early fortification. So although early fortification is safe, but it does not give any advantage in the form of physical parameters or any other clinical outcome. And usually fortification is started for all VLBW babies or babies for preterm and have failure of growth and can be continued till babies are 2 to 2.5 kgs. Now, formula although should not be given to preterms, but it may be needed in certain situations, like if unfortunately mother has expired or mother is on specific drugs like anti-cancer drugs. If the baby has lactose intolerance where we have to give lactose-free formula, mother is seriously ill and there is no availability of donor EBM, or if there is substance abuse in the mother. These are the various preparations of preterm formula which are available in India, and this chart shows their composition. This may be important for trainees and for their exams. Another important question is that why a baby is not growing well. It is maybe because of the critical illness or morbidities like BPD, sepsis, like UTI or anemia, which have to be corrected, or it may be because sometimes because of iatrogenic reasons where we withhold and feeding because of the fear of NEC. Any feed intolerance is taken as NEC, although it may be normal for a premature baby. For babies where we cannot start enteral feeding, the TPN has to be started on day 1 of life. Sometimes this TPN is either not given or only partial TPN is given because of the concerns of cost and the risk of infection. Sometimes EBM is given, which is usually inadequate for calories and proteins. So fortification has to be done to meet the energy and protein requirements. Also, it should not be assumed that babies getting enough calories and proteins. It has to be calculated. It has to be calculated on daily basis depending on the weight. Also, one should be nutritionally sensitive and should provide another supplements like vitamin D, iron to the baby as a norm for preterm babies. So being defensive may not always lead to success. The key to achieve good growth for preterm babies is early feeding, early aggressive nutrition, enteral or parenteral nutrition, depending on case-to-case basis. Overcome the fear of NEC. Do not withhold feeds for minor issues, for any feed intolerance. Always go back to the patient and see whether we can restart the feeds or not. Understand that feed intolerance is physiological in preterm babies, and every feed intolerance is not NEC. Remember that these babies require adequate calorie as well as protein intake, and these should be calculated on daily basis along with calcium and phosphorus. One should maintain a nutritional dashboard as a part of daily notes. Therefore, Aggressive nutrition is key to success for a preterm baby. What one should not do is that regularly do pre-feed aspiration. It can be injurious to the gut mucosa and will not give any benefit. One should not discard if there are milky or clear aspirate because it does not only contain milk but also contains enzymes and juices which are helpful for digestion. Gauze soaked in dextrose and is given to the babies to keep them quiet is not a good practice, can lead to sepsis. Routine use of PPA and H2 blockers have been shown to increase rate of sepsis and have not been beneficial to improve GERD. Antibiotics should not be used left and right. They should be used judiciously. Antibiotic stewardship should be practiced each and every NICU. Take home message is that colostrum is the birthright of every baby and should not be denied. Mother's milk is the best milk. Early aggressive enteral nutrition is the key to success. Gut line is lifeline. Establish it as soon as possible. KMC and non-nutritive sucking are cost-effective and useful adjuncts and should be part and parcel of nutrition bundle. Any questions can be asked in the chat box. Thank you for patient listening.